biggest things, something that has reared its ugly head, even more so now than ever before, is what SADAG faces and faces head on every single day. The South African Depression and Anxiety Group. We're talking about depression, anxiety, grief, and trauma. They have been increasing on a daily basis in South Africa. The organization basically saying that mental health care needs to be prioritized because there is really no health without mental health. According to statistics released by SADAG, fewer than 1 in 10 people with mental illness in South Africa have access to mental health care. Just listen to that figure, 1 in 10 people. And I'm sure that it is even less than that. Now, Professor Bonga Chiliza will give us some insight into the state of mental wellness in South Africa. Professor Chiliza is an associate professor and head of the Department of Psychiatry at the University of KwaZulu-Natal. He is also the immediate past president of the South African Society of Psychiatrists and the deputy editor of the South African Journal of Psychiatry. His research interests include schizophrenia, consultation liaison psychiatry, health services, and medical education. Ladies and gentlemen, please joining us virtually for this panel discussion. Not panel discussion, for this presentation. Please let's welcome Professor Bonga Chiliza.
Good morning, and thank you very much, Leanne. And I'm really sorry that I'm not able to have, I'm not there in the studio. It looks like you are being treated really well by the hosts. Thank you very much to the people that have invited us, Salome and other colleagues from Afrocentric. It is a pleasure to be part of such an important health summit. So I hope you can see my slides, and I'm going to be speaking a little bit about mental health. So what I'd like to speak about is just briefly the global sort of picture of mental health care. And then I'm going to spend a little bit of time talking about some figures around how much the government is spending on public health, mental health care in South Africa, and briefly talk about the private health care perspective. And then I will talk a little bit about what we need to do, I think, from our point of view, in terms of the future going forward. So I will also then just briefly talk a little bit about 2 examples of projects that I really feel if we were able to put our money, if we're gambling or whatever, this is where we should be putting our money on. And I think one of them is around the youth mental health care, and the other one is I think what Barry has already spoken a little bit about thinking about doing projects that are a little bit different perhaps. And we have a project in psychiatry that is around a sort of outcomes-based mental health care project that I will briefly also touch on. So Leanne has already mentioned this, and I think it's really important for us in the healthcare to say that there is really no health without mental health. The biomedical training, people like us who are medical doctors, we're trained in biomedical healthcare and in medical schools. We're taught a very false dichotomy, I think, of this dichotomy that there's a difference or separation between the body and the mind, that some things affect your body and some things affect your mind. It is very clear to us and very clear to perhaps indigenous healthcare practitioners that we speak to, health traditional healers and other people, that there is no such dichotomy. What affects your body affects your mind. What affects your mind definitely affects your body. And as Leanne has also mentioned, SADC has been talking about this, but globally, in the global south, as we call it, countries that are so-called lower middle income countries have got a huge treatment gap. It's said it's up to 90%. And what that means literally is that 9 out of 10 people who have a mental illness like depression and anxiety are not getting the kind of care that they should be accessing. So when we want to talk about what to do in the future, I think this for me is an important point. And the point is this, that we're just not spending enough money and we're just not treating enough people with mental illness. And certainly COVID-19 is one of the things that it's done is really shine a spotlight on mental health care. I think one of the things that took a lot of people by surprise was the mental health care of frontline healthcare workers, doctors, nurses in the frontline, cleaners, people that were working in those COVID wards have really suffered a tremendous amount of trauma, a tremendous amount of depression and anxiety at this time. So what that has happened, what that has made it for us who are working in this space is that to think a little bit about how to support them better, but also to think a little bit about ways and means of trying to support them. And one of the issues that keeps coming on over and over again when we're talking about mental health is the one of stigma. So my understanding of stigma is that it's really about three things. It's a problem of knowledge, it's a problem of attitude, and that leads to a problem behavior. So if we are discriminating against people that have mental illness, and I think there's lots of evidence to suggest this, the problems could definitely be around our prejudice or our attitudes, and certainly a lot of it is around sort of ignorance around mental health illnesses. And so there's a lot of work that we need to do when we have to try and improve the knowledge of people about mental health care, that hopefully will translate into better attitudes, and which is not always the case, but hopefully that will happen, and therefore also hopefully less discriminatory behavior. So I think stigma is such an important part of mental health care. Whenever we're discussing how to sort of address new challenges, how to address people that are not getting care, it really does color in a lot of the work that we do, and in terms of trying to overcome this. And it's very similar in South Africa. I thought perhaps you'd understand this a bit better because race, for example, plays a huge colors everything that we're trying to do when it's about government, whether it's about interventions. Because of the past of our country, because of apartheid and colonialism, I think there is some understanding in that. So whatever interventions that we think about in terms of the mental health care space, I think we really should be trying to make sure that we have stigma at the back of our mind, because that really does influence a lot of what happens with mental health care. So, excuse me. So we were excited a few years ago. I was part of the mental health think tank that Dr. Jorgen Pillay started. And in those discussions, one of the things that came up was that we really do not know how much we are spending as a government on mental health care. We don't have proper data to do this. And Crickland, Sumaya, and Donella from UCT were supported by other colleagues in the mental health think tank, and worked very closely with the Department of Health. And they actually went around the different provinces to try and do a study, which was, according to my understanding, was the first really properly done study of expenditure of mental health care in the public sector in the global south. What they did is they went into different directorates in the different provinces. They worked in different hospitals. There's a paper that they published which details the methodology of what they did, and this is what they found. So basically, they found that South African government spends about 5% of their healthcare budget. This was in 2016, 2017. On average, this is what happens. But as you know, that the health department is really decentralized, and is people get their care from the provinces, and so they looked at the different provinces. And I thought it was quite interesting that there's such a stark difference in how much each province spends on mental health care in South Africa. So it's clear that if you live in the Western Cape or in Gauteng, you're much more likely to get probably better mental health care because they spend a bit more money on mental health care in their province, versus places like Limpopo or Mpumalanga, where it is almost as low as 2% of the budget is spent on mental health care. I think what is also interesting is that for people like us who live in KZN and colleagues that live in Gauteng, this is actually where the mental health care directorates exists, and in some other provinces, unfortunately, like Free State, like Limpopo, there is no mental health care directorate, which are the people that would be pushing for mental health care expenditure within the provincial departments of health. So that's the first point that they found. The second point that they found, which I was surprised by the number, but we kind of expected this, was that the majority of the money by far is spent on inpatient care. And what we mean by that is that it is spent on people that have been admitted to hospital to get mental health care. Most of that money is actually in specialized psychiatric hospitals, and which, as you may imagine, it is really not very close to where the community lives. So the majority of the money that we spend on mental health care is in hospitals and is far away from the community. The third, I think, important point from this study came out was that we spend a lot of money treating people in hospitals, and yet within 3 months, a quarter of them are back in hospital. So clearly there's more that we need to do outside of the hospital to try and keep those people outside of hospitals, and what we call outpatient care or outpatient services or ambulatory care is exceptionally important in order to make sure that we can keep people outside the hospital and mentally healthy. So this is they published the study in Health Policy and Planning in 2019, and again, just to show, this diagram just shows that most of the money was spent on the specialist psychiatric hospitals. Regional hospitals is this one. So those are the big hospitals, tertiary hospitals like Groote Schuur Hospital or Charlotte Maxeke in Johannesburg. And very little money was actually spent in primary health care and the district hospitals. And these are the two sort of areas where you'd expect most people to be able to access mental health care services in these sort of two blocks. And you can see that it's not even 25% of the whole. So that's the first bit of information, which I thought was really useful about what we are spending in healthcare in the government or the private sector, in the public sector. We have access to data from the private healthcare perspective as well. And that magical 5%, which is what the WHO says we should be spending on mental health care, as you can see with the government, in the private sector, they are actually spending below 5%, whether it was in 2018, 2019, or 2020. It's really below 5%. These figures are actually much closer. They appear a little bit further apart, but they're actually much closer to each other. So there wasn't a dramatic decrease. It's just that the way that the table has been set up. But the point is that we are spending probably less money than we should be spending on mental health care in the private sector at the moment. Secondly, what's also interesting is that it is increasing. The amount of money that we are spending in mental health care is increasing. If you look at 2018, this is the line. You can clearly see that it's slightly it's going up every year, and I'm sure in 2022 we'll also see some further increases. So we are spending a lot more money in mental health care, as opposed, for example, to allergies, which has kind of stayed pretty flat, and even endocrine has stayed pretty flat. There's a definite increase in the amount of money that we're spending in the private sector on mental health care. And where we're spending that money, unfortunately, similar to the state sector, the majority of that money is spent in hospitals. The majority of the cost drivers in terms of healthcare expenditure in the private sector is indeed in hospitals. We are seeing some slight increases if you look at the bottom in ambulatory care. So these are outpatient services, particularly in the last couple of years, we've seen a slight increase in that. And one can speculate that perhaps it is due to the pandemic-related anxiety, as Leanne and others have said before me, that a lot more people are more anxious, a lot more people are seeking psychiatric or psychosocial help from their GPs and in other places. I think the 2022 numbers are still a little bit early to show if this is indeed going to remain like that for the rest of the year. But the majority, more than 50% of our expenditure in the private sector is also, unfortunately, in hospital care. And there are a number of reasons why this is, and perhaps we can elucidate this, but obviously the way that the funding model is structured at the moment for the private sector is problematic. The way that the psychiatrists and psychologists are servicing their practice is problematic. I've always said that if you have medical insurance and you become depressed and you urgently need to see a psychiatrist, it's probably easier for you to be admitted to hospital to see a psychiatrist than to get an appointment in our cities. And that's really because there's not enough psychiatrists in our country, but also perhaps the way that their practices are structured is such that they are able to see emergency patients that are in hospitals, maybe even late at night, and yet their outpatient services are fully booked. So we often have stories that hit the news that really affect us, particularly us who are working in psychiatry or mental health care. And this death by Ricky Rick really affected a number of my colleagues and myself. He was a young man. He was a brilliant musician. He was really successful and was doing really well, and was obviously suffering from depression, and he ended his life. It is said he committed suicide, which is the worst outcome for people with severe depression. So it makes us wonder what it is that we should be doing more to try and come up with the scourge, to try and really help the scourge of people that are suffering from depression. I think the other message that often is said by mental health care practitioners is that depression does not discriminate. It affects people that are black, that are white, that are women, that are men, that are rich and that are poor. And therefore, our work has really been cut out for us to really do a lot more in terms of treating people with depression. So what should we be doing? So this summit is really about future focus. It's about saying, what do we need to do to really help improve the state of mental wellness or mental health in our country. And so I'm going to talk a little bit about this study, which was done by the Academy of Science of South Africa, SF, which was published last year, but it's been going on for a number of years. And what they looked at is if we take our current situation, we don't have enough psychiatrists, we don't have enough psychologists in our country. What do we need to do? What do the training and the competencies of the current mental health care practitioners should look like for our current situation? And it's very clear that we should be much more open to using what is called a task shifting or task sharing approach. In other words, working with people that are less skilled, that are less trained, under supervision and in teams to try and treat people with mental illness like depression and anxiety. There's no doubt in my mind that our GPs, our frontline medical officers and medical doctors and nurses should be much more exposed to training during their training and also ongoing around issues of depression and anxiety. There's also a huge gap in terms of substance abuse, substance use disorders that we are not training our people in, I think adequately training our people in. And so when our policy in the state, and I think this is probably where I should kind of stop using the private versus public sector, because as we know with universal healthcare and NHI, we are really going to be doing these things together. There's no doubt that psychologists and psychiatrists should be much more playing a role of leadership. They should be much more playing a role of teaching other cadres in the healthcare system. And as I said, of supervising people that are perhaps less trained, less skilled, and therefore less expensive to employ in the provision of mental health care services. So I think that's probably the way that we should be going forward when we're trying to treat our mental health care going forward. The second point from my side is that, again, Crickland, Doctors Besada and Dokrad came up with this report, which is the Mental Health Investment Case for South Africa. as part of the think tank and was commissioned by the Department of Health, we were asked to do this study that we first did, and then from following up on that study that I've mentioned earlier of how much money we're spending, is to develop a very clear framework that we can use to have ring-fenced funding for mental health and well-being. I think this is kind of borrowed from how successful we have been, I think, with HIV, because there is clear-cut ring-fence funding for HIV in our country, and I think that has also kind of led to the government, to others in HIV care, to seek for funding because it was very much specifically ring-fenced around this. And so Professor London and colleagues put together this investment case report for us. And it's obviously a lengthy document. It's very well thought through, and it's built on the work of going to different provinces and meeting with different people. And these are some of the vital recommendations that they have at the end. There's no doubt for us that in mental health care that we really require a lot more intersectoral collaboration between governments, NGOs, the different departments, etc. If everyone kind of can work better together and to try and impact the social determinants of mental health care, we were much more likely to do well. The second point that I just wanted to highlight is that, as I said already, is that some provinces have got mental health directorates that are well-staffed, are working hard to push the issue of mental health care, and yet some provinces do not do that. And so we should be investing in those kind of structures at provincial level to try and make sure that there are people that can drive mental health care issues. The third point I wanted to highlight is that we should definitely be investing a lot more in research around mental health, and particularly for me in intervention research, to kind of say what is that we can do at a population-wide level, what is that we can do in the schools, etc., to try and help improve the mental health care of people. They also spoke quite a bit about, I think, what has already been spoken by previous colleagues around investing in human resources for mental health, investment in infrastructure for scale-up, and of course, I think embracing technology as well to try and help with innovative service delivery models. And there are some studies that are going, different studies from different universities that are trying to look at using cell phones as tools to try and get, particularly to young people, to try and see what kind of interventions one can do using the mobile networks. And I think most of us have got access somehow to some kind of cell phones. Some of them are smartphones and some of them are not, but there's still some work that can be done in terms of interventions when it comes to using those tools. So the last 2 points that I wanted to make are around this. So the first one is really about youth mental health care. So if I were a betting man, I would definitely say that we should spend a lot more money looking at helping teenagers, high school students. The majority of our serious mental illnesses that we treat actually emanate or start from this age group, the sort of late adolescence, teenage years. And so the more work that we're able to do here, the more we're likely to get our bang for the buck in the future. But also, this is where, because of COVID, there's been a huge amount of upsurge in the youth mental health care crisis, with the number of teenagers engaging in suicidal behavior, in cutting, and those kind of things. And so the WHO and other colleagues are working on different studies to say, how do we engage young people and how do you make sure that we're able to reduce these risky behaviors and also make sure that they thrive. And interestingly, this is actually the one area that has gotten robust data. There's quite a lot of things that we can do at the population level, community level for mental health care, and certainly the one that has gotten lots of research, which is very clear, is these socio-emotional learning programs at schools. So the research is there, and we just need to come up with programs that we can try and implement these things, because it's clear that it is actually best practice in terms of prevention of mental health care. I think at the end of last year, the US Surgeon General released I think they call it an advisory, and he focused on youth mental health, and it was really striking because the US Surgeon General doesn't, this is the first, I think, that I'm aware of that he's spoke about this, and it was a really well-written piece which gave suggestions of what the young people themselves should do, what the schools should be doing, what the parents should be doing, and I suggest all of us to kind of read it. And it was really just focused on sort of making sure that we have culturally competent care for our people wherever they are, and it was I think it was an important piece to try and read, which was basically kind of illustrating my earlier point that we should be focusing a lot more on young people. And then lastly, I wanted to end off with this. This is a project that is led by PsyCMG, which is our private practice psychiatrist group. One of the directors, called Eugene Ellis, has been driving this for a long time, and it's really a project that is trying to get our practices to be a lot more digital. It's an electronic medical records project that is trying to have a place where the entire the entire MDT, multidisciplinary team, can access those records. And I think this is the initial step of this project. And ultimately what we're trying to do is see if we can set up an outcomes-based service type of models that we are trying in the private sector, which we'll then hopefully use when the NHI comes along. And what that, I know that there's a lot of people sort of having wonderful criticisms of outcomes-based service models, but as the previous speaker said, we should be trying these things to see if it would work. And roughly, it just basically says that if you give a group of doctors or team to a certain amount of money to care for a number of people, without giving them money every time they see someone, would that not maybe make a better way of treating people with mental health care? And I think that is certainly worthwhile exploring. So I'd like to say thank you very much, Leanne. I hope people were able to listen to me. We think that we're not investing enough on mental health care. We should be definitely looking at leadership and supervision capabilities of our mental health care practitioners in our training. If I were a betting man, I would put my money on youth mental health care as a thing that we should be trying to focus on. And I definitely think we should be looking at research, of course, particularly interventions research that we should be using, that is locally kind of conducted, that will have our local populations at heart and hopefully will work. Thank you very much for inviting me to this particular summit.
Professor, thank you very, very much. Professor Bonga Chiliza, talking to us about such an important issue, and an issue that affects millions upon millions of South Africans. And I think you came, really pointing out and highlighting some of the big issues that we need to overcome, and access to the care when it is something so important. And I mean, losing people to depression and anxiety, and highlighting, I think, really hitting home as soon as you put up that slide of Ricky Rick, where so many of us just looked up to him and didn't believe that somebody like that could possibly be going through what he was and taking his life that way. I mean, these are everyday people, unfortunately, that succumb to that. So we need to be there and intervene before that happens. But Prof, thank you. Thank you for your time. We know that you've got to get back to lectures, and we do, however, really appreciate your inputs for today.